Hello everyone, I'm Atsushi Tanaka from Saga University. It's our great pleasure to introduce the primary results of the PROTECT study. The PROTECT study was financially supported by Astellas. This is presenter disclosures. Background. As you well know, recent cardiovascular outcome trials demonstrated that SGLT2 inhibitors reduce the risk of cardiovascular events, especially heart failure and CKD-related events in a broad range of patients with type 2 diabetes. Given such evidence and their pharmacological actions, SGLT2 inhibitors are likely to exert an immediate hemodynamic action, resulting in the heart failure and CKD benefits. On the other hand, SGLT2 inhibitors are also likely to have favorable metabolic actions. However, it was uncertain whether SGLT2 inhibitors can protect artery and reduce atherosclerosis. So, the aim of this study was to investigate whether 24 months of treatment with ipragliflozin can delay progression of carotid IMT in Japanese patients with type 2 diabetes. Methods. This was an investigator-initiated multi-center probe-style RCT. Participants were randomly assigned into either ipragliflozin or no SGLT2 inhibitor use control group and received study intervention for 24 months. Carotid IMT testings were performed at baseline and 24 months at each local site, and all the IMT parameters were measured at a central core laboratory in a blinded manner. Individuals eligible for the study were adults who had hemoglobin A1C of 6% to 10%. Detailed exclusion criteria are shown here. The primary endpoint was to assess the group difference in the change in mean IMT of the common carotid artery (CCA IMT) from baseline to 24 months. The key secondary endpoints included other carotid IMT parameters, such as mean and max IMT of the valve and internal carotid artery at 24 months. A total of 488 patients were registered, and 482 patients were equally randomized. Overall, median age was 68 years, about 70% were male. Median diabetes duration was 8 years. Median hemoglobin A1C was 7.3%, and about 40% had been receiving cardiovascular secondary prevention. About 80% of patients had been taking any antihypertensives. 2/3 of patients were on statin treatment, and about 85% were on treatment with any glucose-lowering agents at baseline. Results. As shown here, for the primary endpoint of the PROTECT study, the adjusted group difference in the change of mean CCA-IMT at 24 months was -0.0002, and the p-value was 0.985. This table summarizes the results of all carotid IMT endpoints, and the effect of ipragliflozin on those parameters, such as mean and max IMT of valve and internal carotid artery, were all neutral relative to the control group. Regarding the effect on glycemic parameters, ipragliflozin decreased them over 24 months. The adjusted group differences in those changes at 24 months were significant between the groups. Let me summarize and conclude our study. 24 months of ipragliflozin treatment relative to control did not affect carotid IMT progression in patients with type 2 diabetes recruited to the PROTECT study. Our findings suggest that anti-atherosclerotic effect is unlikely predominant for the cardiovascular benefits of SGLT2 inhibitor within this treatment period. Thank you for collaboration with us. This shows all the PROTECT study investigators. Thank you for your dedicated contribution to this study, and thank you for your attention and listening.
Hello everyone, I'm Kojima from Sakura-jyuji Yatsushiro Rehabilitation Hospital. I think it's a great honor to announce my paper in this webinar titled Optimal uric acid levels by Febuxostat treatment and cerebral cardiorenovascular risks. This study is a post-hoc analysis of a randomized controlled trial. This is my COI. Hyperglycemia is characterized by abnormally elevated serum uric acid levels and is recognized as an independent risk marker for cardiovascular and renal diseases. Excessively low serum uric acid levels may also predict all-cause and cardiovascular mortality, indicating a J or U-shaped relationship between serum uric acid and the risks. However, this association was identified in observational or retrospective studies. The target serum uric acid levels to be achieved by treatment have not been established by current guidelines for the management of gout, owing to the lack of sufficient evidence to support lower thresholds. We previously performed FREED, which was a multi-center prospective randomized open-label blinded endpoint study, demonstrated that serum uric acid levels by Febuxostat was associated with greater reduction in the incidence of cerebral, cardiovascular, and renal events in patients aged 65 years with asymptomatic hyperglycemia than in their counterparts who underwent conventional therapy with lifestyle modifications. However, the FREED did not report any adverse events owing to excessive reduction in the serum uric acid levels. So the purpose of this study is to explore whether interventional treatments for excessive serum uric acid, SUA, reduction were harmful and what constituted the optimal lowering of SUA levels for the prevention of events in older patients with hyperglycemia who are at risk for cerebral or cardiorenovascular disease. Method. This study is a post-hoc analysis of FREED's data, which included 1,070 patients, with 537 assigned to the Febuxostat group and 533 assigned to non-Febuxostat group. They were categorized into 4 to 5 a priori defined groups according to achieved SUA levels. 5 groups in the Febuxostat and 4 groups in the non-Febuxostat group. Fatal and non-fatal cerebral, cardiovascular, and renal events and death owing to causes other than cerebral or cardiorenovascular disease during the study period were defined as primary composite endpoints in the study. This table shows the distribution of primary endpoints and each component of primary endpoints versus the achieved SUA levels in the Febuxostat and non-Febuxostat groups. In the Febuxostat group, the primary composite event was observed in 25% of the patients who achieved SUA levels less than 4 and 4 to 5 and 6 to 7 milligram per deciliter during the study period. This rate was almost twice that observed in patients who achieved SUA levels of 5 to 6 milligram per deciliter. Further, the rate at which patients achieved SUA levels more than 7 milligram per deciliter was more than 3 times compared to the rate at which patients achieved SUA levels of 5 to 6 milligram per deciliter. The Kaplan-Meier curves in the Febuxostat group are shown in this figure. There was a significant difference among the 5 groups. Patients who achieved SUL levels less than 4, 4 to 5, 6 to 7, and more than 7 milligram per deciliter had significantly higher hazard ratios than those with reference SUL levels of 5 to 6 milligram per deciliter after adjusting for stratification factors for randomization, indicating a J-shaped phenomenon. In the non-Febuxostat group, the primary composite endpoint was observed in 25 to 30% of patients across the subgroups defined by the achieved SUL level. No significant difference was found for any level compared with the reference level of 5 to 6 milligram per deciliter, although the figure appeared to be J-shaped. Uric acid acts as an antioxidant in the extracellular circumstances, but acts as a pro-oxidant inside cells. Therefore, the dual role of UA as antioxidant and pro-oxidant has made us confused to date. Equilibrium may be maintained even in patients with hyperglycemia in non-Febuxostat group. That is a balance between beneficial effects of UA as antioxidant and the detrimental effects of UA and comorbid. Unsatisfactory reduction of the SUA levels leads to comorbid instability in the condition of achieved SUA levels of more than 7 milligram per deciliter. Meanwhile, UA contributes to more than 50% of human plasma antioxidant capacity. Excessive reduction of UA by Febuxostat treatment may not correct antioxidant imbalance, leading to cerebral and cardiorenovascular events by extremely decreased antioxidant effects, but less exacerbation caused by pro-oxidant UA levels. So we conclude that Febuxostat treatment for achieving SUA levels of between 5 and 6 milligram per deciliter reduced the composite of all deaths, cerebral, cardiovascular, and renal events with a pronounced effect compared with SUA levels of less than 4, 4 to 5, 6 to 7, and more than 7 milligram per deciliter. And excessive SUA reduction may be harmful in participants with hyperglycemia. These hypothesis generating data highlight the potential of the harm owing to hyperglycemia and hypoglycemia in a high-risk aged population and warrant prospective confirmatory studies to identify population that might benefit from specific target SUA levels attained with Febuxostat treatment. This paper has been recently published in Rheumatology. We will be happy if you are interested in this study and check our paper. Thank you for your attention.